Respected President Dr. G.S. Vijayakrishnan, respected Dr. Padmanabhan sir, respected faculty Dr. R.I.YAZ, respected senior leaders like Dr. Iqbal, respected senior members, dear AMS members, dear colleagues and friends. I'm really glad to welcome you for our journal club, the 4th program in the month of May. Actually, we're planning for 2 more programs, which we had to cancel due to some the unfortunate, shocking incidents that happened at Kottaragram. We'll be conducting it the month of June. And I'm really glad to announce that we were honored by the IMA Kerala State Branch by giving us the responsibility of conducting the Kerala AMS South Zone Conference. We'll be doing it in July in a very grand scale. It will be an academic feast. I request all of you to register, participate, and make it a huge success. And I don't want to spend much time speaking, and I'm coming to the present day program. It's going to be a very interesting, very informative, a fantastic session, because we know when the speaker is great and the topic is fantastic, the session has to be good. Now, I really welcome Dr. Vijayakrishnan, our respected president of IMA Trivandrum branch, who is always a great support to our AMS activities, gives a lot of ideas, suggestions, corrections, and etc. etc. Welcome, Dr. G.S. Vijayakrishnan.
Thank you.
And Dr. Padmanabhan sir, he needs no introduction. He's a very senior pediatrician, a senior academician. He's a HOD of Pediatrics, VRS Hospital. He has been coordinating the our AMS Journal Club along with Dr. Anju.K.Kanmani ever since we started the Journal Club in December. Welcome, sir.
Thank you. Thank you.
And Dr. Anju.K.Kanmani is a consultant pediatrician and Thaluk Hospital, Vithura. He's one of the coordinators. Actually, it's his enthusiasm that is making this happen every month without fail. And today, I think he's yet to join. He'll be joining. He said he'll be joining somewhere in between. And I welcome him, Dr. Anju.K.Kanmani. And Dr. R.I.YAZ, he's an associate professor in the Department of Pediatrics, SATH Hospital, Trivandrum. And he's in charge of the Pediatric Endocrinology Division and the famous Mithai Club, a person, the lovely smile, a lot of academic skills, organizational skills. He was the Trivandrum branch secretary of IAP. Later on, he became the IAP state joint secretary, state treasurer, and went on to become the state secretary of IAP Kerala. He was also the president of IMA Kalputtam branch. More than that, he's a friend of, well-wisher of our AMS Trivandrum chapter. I remember with gratitude that he makes it a point to attend all our major functions. And he's also a member of our organizing committee of the South Zone South Zone AMS conference. And welcome, Dr. R.I.YAZ. And Dr. Altaf, our Honorable Secretary, IMA Trivandrum branch. He's also yet to join. He's busy with some other program, and he'll be joining in between. And I welcome Dr. Altaf also. And I welcome all the senior leaders, my colleagues, my friends, dear AMS members who's participating in this program. And now I welcome Dr. G.S. Vijayakrishnan to say a few words. Over to you, Dr. G.S. Vijayakrishnan.
Thank you, sir. Respected Chairman of IMA Trivandrum AMS, Dr. Pradeep Kadangur, sir. Respected Padmanabhan, sir, Iqbal, sir, Dr. Riyaz, and respected seniors and dear friends. Trivandrum IMA AMS. എല്ലാ തവണയും പറയുന്ന പോലെ കഴിഞ്ഞ എല്ലാ മാസവും വളരെ സ്ട്രക്ചേർഡ് ആയിട്ട് നമ്മുടെ മെമ്പേഴ്സ് ഫ്രണ്ട്ലി ആയിട്ട് ഒരുപാട് പ്രോഗ്രാംസ് നടത്തി മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നു. കഴിഞ്ഞൊരു മാസം നമുക്ക് കുറച്ച് ബുദ്ധിമുട്ടുണ്ടായിരുന്നു. അൺഫോർച്ചുനേറ്റ് ഇൻഷുറൻസ് പ്രദീപ് സാർ പറഞ്ഞ കണക്ക് നമുക്ക് ഉണ്ടായിട്ട് കുറെ ആക്ടിവിറ്റീസ് നമ്മൾ മാറ്റി വെച്ചിരുന്നു. പക്ഷെ എങ്കിലും വീണ്ടും നമ്മുടെ IMA മുമ്പോട്ട് പോയെങ്കിലേ പറ്റുള്ളൂ, പ്രൊഫഷൻ മുന്നോട്ട് പോയെങ്കിലേ പറ്റുള്ളൂ. പ്രൊഫഷനായിട്ട് ബന്ധപ്പെട്ട ഒരുപാട് ഇഷ്യൂസ് ഈ കാലഘട്ടം നടക്കുന്നുണ്ട്. നമുക്കെല്ലാം അറിയാം, നമുക്കൊരു പുതിയൊരു ഹോസ്പിറ്റൽ പ്രൊട്ടക്ഷൻ ആക്ടിന്റെ അമെന്റ്മെന്റ് ഓർഡിനൻസ് ആയിട്ട് വന്നിട്ടുണ്ട്. വളരെ ബുദ്ധിമുട്ടി നമ്മുടെ സംസ്ഥാന നേതൃത്വം IMA മെമ്പേഴ്സ് എല്ലാവരും ചേർന്നുള്ള ശ്രമഫലത്തിന്റെ ഭാഗമായിട്ടാണ് നമ്മുടെ ഒരു സഹോദരി നഷ്ടപ്പെട്ടെങ്കിൽ പോലും നമുക്കൊരു ഓർഡിനൻസും ആക്ടും ഒക്കെ വന്ന് ഒരു സുരക്ഷിത മേഖലയായിട്ട് നമ്മുടെ ആശുപത്രികളും ഡോക്ടർമാർക്കും വർക്ക് ചെയ്യാൻ പറ്റുന്ന സാഹചര്യത്തിലേക്ക് നമ്മൾ ചിന്തിച്ചുകൊണ്ടിരിക്കുന്നത്. അതൊരു ഓർഡിനൻസ് മാത്രമാണ്, ഒരു ആക്ടായിട്ട് നമുക്ക് കൊണ്ടുവരേണ്ട ആവശ്യമുണ്ട്. അതിനുവേണ്ടി എല്ലാവരുടെയും ശ്രമഫലങ്ങൾ നമുക്ക് ആവശ്യമാണ്. എല്ലാ മെമ്പേഴ്സിന്റെയും എല്ലാവരുടെയും നമ്മുടെ സൊസൈറ്റിയുടെയും മീഡിയയുടെയും പൊളിറ്റീഷ്യൻസിന്റെ എല്ലാ സപ്പോർട്ടും നമുക്ക് ആവശ്യമുണ്ട്. അതിലേക്കായി നമുക്ക് ഒന്നിച്ച് മുമ്പോട്ട് പോകാം എന്ന് മാത്രമാണ് ഈ അവസരത്തിൽ പറയാനുള്ളത്. കൂടെ തന്നെ നേരത്തെ സാറ് പറഞ്ഞ പോലെ തന്നെ AMSന്റെ സൗത്ത് സോൺ നമ്മുടെ കോൺഫറൻസ് ട്രിവാൻഡ്രമാണ് ഹോസ്റ്റ് ചെയ്യുന്നത്. നമുക്കതും ഭംഗിയായിട്ട് നിറവേറ്റണം. നമുക്കെല്ലാം അറിയാവുന്ന പോലെ നമ്മുടെ നാഷണൽ കോൺഫറൻസ് ഡിസംബറിൽ വരികയാണ്. ഒരുപാട് ഹെക്ടിക് ആയിട്ടുള്ള ആക്ടിവിറ്റീസ് ആണ് IMA ട്രിവാൻഡ്രം ഈ വർഷം മുമ്പോട്ട് വെച്ചുകൊണ്ടിരിക്കുന്നത്. എല്ലാവരുടെയും സപ്പോർട്ട് അത്തരം കാര്യങ്ങൾ ഉണ്ടാവണം. രജിസ്ട്രേഷൻ ഉൾപ്പെടെ, രജിസ്ട്രേഷൻ മാത്രം പോരാ, ഒരു പാർട്ടിസിപ്പേഷൻ നാഷണൽ കോൺഫറൻസ് ഉൾപ്പെടെ നമുക്ക് വേണം. കാര്യം 56 വർഷങ്ങൾക്ക് ശേഷമാണ് IMA ട്രിവാൻഡ്രം കേരളത്തിൽ തേർഡ് ടൈമാണ് നമ്മൾ നാഷണൽ കോൺഫറൻസ് നമ്മൾ ഹോസ്റ്റ് ചെയ്യുന്നത്. അപ്പൊ അതിന്റെ ഒരു പ്രൗഢിയോടുകൂടി നമുക്ക് മുമ്പോട്ട് പോവുകയും വേണം. പ്രത്യേകിച്ച് 90ാം വാർഷികം ആഘോഷിക്കുന്ന നമ്മുടെ ബ്രാഞ്ച് എനിക്കൊന്ന് ഇന്ത്യയിലെ തന്നെ ഏറ്റവും ഓൾഡസ്റ്റ് ആൻഡ് ലാർജസ്റ്റ് ബ്രാഞ്ച് എന്ന രീതിയിൽ തന്നെ IMA ട്രിവാൻഡ്രത്തിൽ ലെഗസി സൂക്ഷിച്ചുകൊണ്ട് നമുക്ക് മുമ്പോട്ട് പോകണം. കൂടുതൽ ദീർഘിപ്പിക്കുന്നില്ല. ഈ നമ്മുടെ ഇന്നത്തെ ജേണൽ ക്ലബിന് പീഡിയാട്രിക് ഹൈപ്പോതൈറോയിഡിസം എന്ന രീതിയിൽ വന്നേക്കുന്ന ഇന്നത്തെ ഒരു CMA സെക്ഷന് എല്ലാവിധ ഭാവങ്ങളും നേരുന്നു. ഡോക്ടർ റിയാസിനും നമ്മുടെ ഈ പ്രോഗ്രാമിൽ പങ്കെടുത്ത് നമുക്ക് വേണ്ടി പ്രോഗ്രാം ചെയ്ത റിയാസിന് പ്രത്യേകം നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് നിർത്തുന്നു. താങ്ക് യു, സർ.
Thank you. And over to you, Dr. Riyaz, to present the article and discuss. Thank you.
Thank you, sir. At the outset, I express my sincere gratitude to Pradeep sir, Anju in his absence, as well as Dr. Vijayakrishnan, Padmanabhan sir, and all the seniors for giving this opportunity. Today what we are going to do is we are going to look at the most recent guideline on the management of congenital hypothyroidism. I'm sharing the screen. I think the screen is visible, no?
Yes, yes.
Okay. Congenital hypothyroidism is actually, I should consider it, and everyone should consider it, not as a pediatric topic, but it is something which every physician should be knowing, because all babies, like all the deliveries, may not be attended by a pediatrician all the time. And we need to spread the message of screening for congenital hypothyroidism. That is why this becomes a relevant topic. And as everybody know, we had published an Indian guideline in 2018, which was published in the Indian Journal of Pediatrics. and is being followed in most of the parts in our country. And now we have a recent guideline which came from the European Society of Pediatric Endocrinology as well as European Society for Endocrinology in 2021. And this guideline was actually a outcome of a meeting where the Endo-European Reference Network took an initiative. They selected around 22 participants from different parts of the world, and they have actually reviewed the articles starting from 2013, and the activity actually lasted till 2019. And the reviewed article were considered for making up this particular guideline. And actually the writing group was consisted of five particular, they considered 5 particular areas, namely neonatal screening, diagnosis and criteria for treatment, treatment and monitoring, outcomes of neonatal screening and early treatment, genetics of congenital hypothyroidism, and antenatal management. And this is just for an introduction of how do we read a guideline. So we need to look at the numbers which are given along with the recommendations. So number 1 means it is a strong recommendation. That is, it can be applied to most patients, and it is clearly established that the benefits outweigh the risk. 2 means it is a weak recommendation. That is, it is suggested by the guideline committee, but it need to be evaluated on patient-to-patient basis, and because the risks are closely balanced, or some of the recommendations may be uncertain also. So it means that in any guideline, if you are seeing 1 with the recommendation, that means it's a strong recommendation, and 2, we need to take it as in a case-to-case basis. And also there will be, along with this 1 or 2, there will be this notation that is number of plus. So if it is only 1 plus, it has a low quality of evidence. That is, it's a case series or a non-systematic clinical observation, maybe an expert opinion, something like that. Moderate means it is actually the particular recommendation is established through studies, but there are some methodological flaws in those studies, and there are some inconsistent evidence. It is not the same in different studies. And 3 plus means, that is plus if you are seeing along with the recommendation, that means it is a high quality recommendation. So remembering this will be useful while we are reading the recommendations in this article or any guideline which we read up. So first about neonatal screening. So the first recommendation is actually early detection and treatment of congenital hypothyroidism through neonatal screening, prevent irreversible neurodevelopmental delay, and optimize the developmental outcome. This is a strong recommendation with a very high level of evidence. And the guideline also recommends introduction of screening worldwide. And we should remember that even though the screening for congenital hypothyroidism started in the West in 1956, in India, it is not universal till today. So we need to introduce the screening, and all of us as pediatricians or common physicians or any doctor who is in any specialty need to make sure that every baby born is screened for congenital hypothyroidism, because we know congenital hypothyroidism is the most important and most common cause of preventable intellectual disability. So the incidence is actually for congenital hypothyroidism is different from different studies. It starts for primary congenital hypothyroidism, it is to the tune of 1 in 3,000 to 1 in 2,000. And in some parts of our state, we have got a data of 1 in 1,500 and even lesser, 1 in 1,000 also we have got. And central congenital hypothyroidism is actually 1 in 16,000. Central congenital hypothyroidism means there is a problem with the pituitary or the hypothalamus. Primary congenital hypothyroidism means there's a problem with the thyroid. So most of us actually, when we are doing the screening, we measure the TSH. We measure the TSH, that is thyroid stimulating hormone level. Why TSH is measured is because the primary congenital hypothyroidism is the most common thing. That is, it occurs to the tune of 1 in 2000 or 1 in 1000. So that means it is the most common one. And to detect that, we have to measure the TSH, because TSH will be high in all cases of primary congenital hypothyroidism. But only looking at the TSH will definitely, we will miss central congenital hypothyroidism, but it is a rarer disease. If we need to screen for central congenital hypothyroidism, also we have to do a screening of TSH and free T4, TSH and free T4 or total T4. TSH and T4 together should be done in all babies born. So that's about how to screen. Then for a particular group of babies, especially those babies who are preterm, who are low birth weight and who are sick babies, initial screening may not be enough. Initial screening may not be enough. So in such babies, it is always better to repeat the screening. That is, even though we have done a code TSH or we have done a TSH at 48 hours of life, we need to repeat the screen after around 1 to 2 weeks of life, because these babies can have a false negative report initially. So we need to repeat for them. And for babies who are having Down syndrome, we need to repeat the TSH at the end of the first month of life. So that is also important. And in twins, we may miss an affected twin in the initial screen. So all twins should have a repeat screen at the end of 2 weeks again. And whenever you see a baby, even though you are having a neonatal screen negative, neonatal screen normal, do a thyroid function test if you are suspecting hypothyroidism clinically, because it is a very simple test which is universally available and which will change the life of the child. And for diagnostics, for the criteria, what we do is we have to do the we have a TSH value, and if you are getting an abnormal result after doing a confirmatory serum free T4 or TSH, the child need to be treated. And whenever there is a value of TSH which is more than 20, whenever there is a TSH more than 20, even if the free T4 is normal, we have to start treatment. So that is how we go about it. So initial TSH more than 20, we will call back the patient again, and we will repeat the test. And in the confirmatory sample also, if the TSH is more than 20, even if the T4 free T4 is normal, you have to treat that particular baby. So this is how the ISPE guideline 2018, which all of us use, goes about. It is TSH when it is more than 20, you have to recall the baby. So even if you do the TSH from the cord blood or using a heel prick after 48 to 72 hours of life, the cutoff is again more than 20. So whenever you have a TSH of more than 20, you have to call the baby back. So that recall can be immediate, that is at 72 hours if the TSH value is more than 40. And the TSH, if the TSH is between 20 to 40, if the TSH is between 20 to 40, you can recall the baby in the second week. It is because when the TSH is between 20 to 40, there is a possibility it is a temporary issue. It may be because of some drug, it may be because of some error in the testing, all those things. So give some time for the baby to settle down those problems. So call the baby in the second week. But if it is TSH is more than 40, most of the time it is permanent congenital hypothyroidism. So you have to call the baby early. And when the baby is called back, we have to repeat the TSH along with a free T4 or total T4 value. And remember, we need not remember all these values. It is very difficult, but always remember a value of free T4 of less than 1 or a value of total T4 of less than 8 in a newborn is always abnormal. That baby needs treatment, whatever may be the TSH. And if the TSH is more than 20 on confirmatory sample, on the repeat sample, that baby also needs treatment. And this is a different recommendation. This is when the TSH is between 6 to 20, in the healthy neonate more than 21 days. Even though the free T4 is normal, we can either start the baby on treatment, or we can withhold the treatment and retest 1 to 2 weeks later and reevaluate the need for treatment at a later date. So this is a little different from what the SPE says. What the SPE 2018 says is, if the serum TSH concentration is 10 or more beyond age of 21 days, you have to start treatment. And we will retest the baby off treatment at a later stage, that means at the 3 years of age. But the new recommendation has bring down that cutoff to 6. So here what they say is, if it is between 6 to 20 in a baby more than 21 days, even though the T4 is normal, only TSH is elevated, but T4 is normal, you have 2 options. Either you start the baby on treatment and follow up the baby, adjust the doses accordingly, or withhold the treatment, but keep the baby under strict follow-up. Every 1 or 2 weeks, you can retest and then later visit. So these 2 recommendations are actually not very different. But here, what they were telling is, all babies with a TSH more than 6 at an age of 21 days need to be under our scanner. But the SPE 2018 was telling, we need to scan or we need to treat babies only with TSH more than 10. So that is the difference in the new recommendation. So whenever you are having a free T4 low and TSH is low, we need to consider central congenital hypothyroidism. So in our usual routine screening, if you are doing only TSH, we may not identify such cases. So by doing clinical examination also, so that is for babies who are having a cleft lip, a cleft palate, a micropenis, a baby who is having a mid-facial hypoplasia, always do both T4 and TSH. Only if we do a T4, we will identify a central hypothyroidism. And once you identify a central hypothyroidism, we should always remember it could be a part of a hypopituitarism. So in such cases, always do a cortisol also. And if the cortisol is low, we need to supplement with hydrocortisone first, and then only start thyroxine. So that is something we should all remember. And regarding the communication of an abnormal neonatal screening, what does the guideline says is, the communication should be done by an experienced professional. This is very, very important, because this is something which you're going to tell the newly born parents. Actually, the parents are also newly born. To them, we are going to tell that your baby needs lifelong treatment. It is not a simple thing. So it should be told by an experienced professional. It is always better the pediatrician or the treating doctor should say. It should not be given as a job of the receptionist or the nurse or someone. And always better face-to-face. We can just tell them that the result is abnormal, there is some problem, and then ask them to come and then explain everything, rather than telling them through phone that the baby is having hypothyroidism. And regarding the imaging techniques, so in most of the cases, when we identify congenital hypothyroidism, parents will be asking why this is happening. So we need to tell them, or we need to give them an etiological diagnosis, like what is happening to the gland? Is the gland not formed? Is the gland having only one lobe? Is the gland small? Or is the gland there, but it is a lazy gland which is not making the hormone? So all those questions can be answered only if we do a imaging. So we have 2 types of imaging. One is doing a scintigraphy, that is a nuclear scan using technetium. or we can use a ultrasound. So which is better? That question always stays. So what to choose? So this is actually the ultrasound of a baby who had a congenital hypothyroidism. So we can very well see the radiologist has beautifully described the size of the lobe, the right lobe, the left lobe, everything. But when we did a scintigraphy, we are seeing that there is no thyroid gland at all. So in the neck, there is no uptake, there is no thyroid gland. So when you search the literature, you can see it is very much possible that the fascia over the anterior part of the neck can be easily identified as a thyroid gland in very small babies. So which is best? The best one will be a technetium scan, but technetium scan may not be available in all parts of our state or country. So even if you do an ultrasound, that is fine. But the most important thing is we need not wait for an imaging result to start treatment. Starting treatment is an emergency that we should do as early as possible. And always look for congenital malformation. Renal and cardiac anomalies are common with the babies who are having congenital hypothyroidism, so that we need to look at. And regarding the treatment and monitoring of congenital hypothyroidism, the only choice of treatment is levothyroxine, and we should know that levothyroxine is available only as a tablet. There is no syrup or powder form or nothing else. And people say if you start the treatment within 2 weeks of life, not many IQ points are lost. So the best results we get if we start the treatment within 2 weeks of life. And the starting dose can be anywhere between 10 to 50. This range is given because there is mild to moderate to severe congenital hypothyroidism. So if it is a severe congenital hypothyroidism, that means you are having a high TSH value and very low T4 or free T4 value on confirmation. This child needs a higher dose of treatment. That means the dose will be somewhere near 15 microgram per kg per day. So if it is a mild congenital hypothyroidism, like you are having a mildly elevated TSH, like a 25 or 30, something like that, and a free T4 value in the borderline. I told any value less than 1 is abnormal. So you are seeing a value of 0.8, 0.9, you start with a 5 to 10 value. So that is it. And this LT4 or levothyroxine should be administered orally once a day. It is always better to give it in the same time. Conventionally, we all tell that it can be given in the morning. So it is actually, if there is nothing will happen if we give it night, but it need to be given at a particular time. So we pediatricians usually tell the mother that you brush the teeth and give the medicine to the baby, so that it is connected with a routine activity, so that the mother doesn't miss the drug, because giving a drug every day is not easy. And once the child starts brushing teeth, we can tell the child, you brush the teeth and take the drug in the early morning. And it is always better to avoid other drugs, especially iron, soya, calcium, along with thyroxine. And regarding the brand and generic, what they recommend is, in their personal opinion, the brand will be better. And regarding the monitoring, when to monitor. So when you are asking the child to, or the parents to come with a thyroid report, always make sure it is not, the sample is not taken immediately after taking the thyroxine value, because that can affect the value. It is always better to take the blood before giving the morning tablet. Or if the morning tablet is given, take the sample in the afternoon. That will be better. At least 4 hours should be there. And our aim is to normalize the T4 as early as possible. So that is very, very important. So we need to monitor it very, very closely. So even when you are seeing a value of a free T4 or T4 above the upper limit of the reference level, and you are seeing that the TSH is normal, and there is no sign of hyperthyroidism, you accept that value. That is always better. It is because in the hurry to correct this high value, if you reduce the dose, the child may have the risk of hypothyroidism in the initial days. So we can accept a free T4, a single value of free T4 above the upper limit of the this thing. So when to do this? When you start the treatment at 2 weeks, we have to do because we have to make sure that the LT4 in circulation or the thyroxine, the T4 in circulation is normalized as early as possible. So if you are seeing a baby who is having severe hypothyroidism, like the TSH value is like more than 500, and the free T4 value is 0.1 or 0.2. So we may start with a very high dose, like 50 microgram every day. So at the age of 1 week, we can see whether the patient has normalized. So it will take some time for the blood level to normalize because the thyroxine is a drug which has a longer half-life. And subsequently, every 2 weeks until complete normalization of serum TSH. And thereafter, once every 1 to 3 months until the age of 1 year. And after that, every 3 to 6 months till age, the growth is completed. And whenever you have a abnormal free T4 or TSH, the first thing we should ask should be compliance, because we know taking a medicine every day, all of us don't even complete the courses of antibiotics for 5 days or 1 week. So we should always be in the lookout for compliance. And every time you change the dose, after 4 to 6 weeks, we have to repeat and see whether the adequate amount of thyroxine is maintained in blood. That is very, very important. And one important issue is where for the breastfeeding baby, we need to give the thyroxine along with breast milk, because we have this exclusive breastfeeding policy. So up to 6 months, we can give it mixed with breast milk. And also for older babies, it is not necessary that we need to keep a half an hour or 1 hour interval with food and all, but avoid soya protein and as well as drugs like calcium and iron given along with the thyroxine. And when there is a central congenital hypothyroidism, what you are going to look at is the free T4 value, because we cannot look at the TSH value, because the TSH will always be low or normal. So we will start with 10. Usually we can start for congenital for central hypothyroidism at a lower dose than for a lower dose. With a lower dose, we can treat central hypothyroidism. So start with 10 microgram. And if it is a milder central hypothyroidism, we can even start with a lower dose. And when we are looking at the values, whenever you are seeing a TSH is low, and the TSH is low, and the free T4 is in the lower limit, like the free T4 is lower limit and TSH is in the normal range, that is TSH is more than 1 and the free T4 low, we may have to increase the dose. Because what happens during the treatment of congenital hypothyroidism is TSH will be suppressed. Even if the TSH was normal at the time of treatment, because diagnosing central hypothyroidism is a little difficult, because the TSH will be low in some cases, but most cases TSH will be normal. So what we have to remember is when free T4 is low, TSH has to increase. So if you are seeing that free T4 is low and TSH is normal, that is a inappropriately normal TSH. So inappropriately normal TSH actually indicates central hypothyroidism. So we should not expect a low TSH, like a 0.5 TSH or a 0.3 TSH. TSH can be even 2 or 3 in congenital central hypothyroidism. And the free T4 or T4 will be low. So that is the clue. And when you are seeing that the TSH is increased, TSH is more than 1 and free T4 is below the lower limit, you have to increase the dose of the thyroxine. And always remember, normal is not the same always. Because it is different for different ages. When you look at the lab values, labs will be giving a different impression to us. So just look at the first line. So 1 to 3 months, actually a T4 value of up to 18.3 microgram per DL is normal. For us, it is actually hyperthyroidism. And a TSH value of up to 5 or 5.57, everything is normal for a newborn or a child. And actually for infants, we can take a TSH up to 10 as normal, provided the free T4 and the T4 is in the upper half of the normal limit for that particular age. So diagnostic re-evaluation. Because in some babies, we start the treatment, we were not able to do the imaging. So we don't know whether this was warranted or not, especially for those babies who are having a free T4 normal, but TSH was more than 10, even after 3 weeks of life. We will start treatment. So for such babies, we need to make sure that this is a permanent congenital hypothyroidism. So that opportunity comes around 3 years of life. So our classical teaching is up to 3 years, the brain growth is happening. So we need not decrease or we need not stop the drug till that time. Then after that, we can stop and reevaluate. So how to do that? You can either phase out over 4 to 6 weeks period. That means at the age of 3 years, what we do is we reduce the dose. So the child was at 25 microgram. We would reduce it to 12.5. Then do a TSH after 2 weeks or what you call 4 weeks. We do a TSH and T4. And it is not increasing. The TSH is not increasing and T4 is not falling. And stop it. And then again after 2 weeks or 4 weeks. So like that also we can do. Or we can altogether stop and do after 4 weeks. Because after the age of 3 years, stopping for 4 weeks, even in a child who is having congenital hypothyroidism, may not affect the brain growth much. So that is the rationale for that. Now, our new recommendation tells us that if you are seeing like there is no feature of permanent congenital hypothyroidism, that is, we have not done an imaging, we have done an ultrasound, and you are seeing the thyroid gland is well formed, it is proper. You have done a technetium scan, it is normal, but because of doubt, as the TSH was high, we started. So for such babies, if the dose requirement is less than 3 microgram per kg per day, the new recommendation tells us that at the age of 6 months, we can stop and reevaluate. So it is only for such babies where in the imaging the thyroid gland is present and the requirement of thyroxine is negligible, like less than 3 microgram. So in such cases only, we are permitted to reevaluate at an age of 6 months. For all other babies, the reevaluation should happen only after 3 years of age. And a word about monitoring of pregnant women with congenital hypothyroidism, because I'm sure that those babies who were treated by Pradeep sir and all, I have seen Ashok sir also, may have become mothers and grandmothers, at least a few. So they may come back to our pediatrician and ask about the TSH value. So the recommendation tells us that we need to increase the dose of thyroxine during pregnancy, because pregnancy is a state where the need for LT4 is very high. So, and here the titration happens with TSH actually. Usually in children, we always look both at TSH and T4, but in pregnancy, we need to look at the TSH. So in all trimesters, the TSH should be less than 2.5 milliunits per liter if it is a mother who was on treatment for congenital hypothyroidism. So that is a very, very important thing. So sometimes we will reach values of T4 1.5 times the normal, but that is okay during pregnancy. And 6 weeks after postpartum, we need to reduce the dose to the pre-pregnancy levels. And regarding the outcomes, what will happen to these babies if you treat? So they have looked at the neurodevelopmental outcomes, the development of goiter in thyroid dyshomogenesis, growth, puberty, fertility, bone metabolic and cardiovascular health, etc. And what they tell is there is a more incidence of speech delay, attention and memory problems and behavioral problems. And there's some significant psychomotor development delay can also occur in some babies where there is some syndromic associations and other brain abnormalities. And neonatal and repeated hearing tests are important in babies with congenital hypothyroidism. This repeated hearing test, all guidelines tell about, ISPE also tells, because the development of the cochlea and the inner ear actually happens even after birth. So for that, thyroxine is necessary. So we need to look at the hearing even after birth during therapy. So, some babies who are having dyshomogenesis, that is, dyshomogenesis means the gland is there, but it is not producing enough hormones. There is some deficiency of the enzymes, so hormones are not produced enough. So what happens here is there can be development of goiter and nodules. So for that, we will keep the TSH at a lower rate than the other types of congenital hypothyroidism, because we need to keep the size of the gland also under control. So for that, we will keep the TSH at a lower part of the normal range. And as we know, some of these nodules can very rarely progress into the malignancy. So if you are seeing a nodule in a dyshormonogenetic goiter, we need to follow it up with ultrasound and, if needed, an FNAC. And babies who are treated with thyroxine from early life have normal growth and puberty and normal fertility and normal bone metabolic and cardiovascular health. And medical education about congenital hypothyroidism should be improved at all levels with regular updates. It is very important. We need to educate not only pediatricians, we need to educate every physician as well as nurses and also parents. Education of parents is paramount, because regarding the screening, sometimes parents opt out of screening, because in some places it will be a panel, many tests together, so they may opt out. So that should never happen. 2 screenings should always happen in a newborn baby. One is hearing screen and second one is screening for congenital hypothyroidism. These 2 we should always remember. And regarding adherence of treatment, if the parent is well educated, the adherence will be better. That is very important. And transition to adult care, whenever the child is going into the adult age, we need to transfer the care to the adult physician, and also the quality of the care is to be maintained. Then a word about genetics of congenital hypothyroidism and regarding genetic counseling and antenatal management. So we know that some forms of congenital hypothyroidism are inherited, like dyshomogenesis. It is actually an autosomal recessive condition where there can be inheritance, and very few forms of dysgenesis also can be inherited. So if there are multiple members in the family affected, we may tell them about genetic screening. That is, pregnant women, when there is a positive history of non-syndromic congenital hypothyroidism, when there is a syndromic congenital hypothyroidism, unexplained abnormalities in the thyroid profile, or an infant who is having other problems other than the congenital hypothyroidism. Along with congenital hypothyroidism, if you have deafness, neurological signs, etc., or family history, consanguinity, all these babies may be offered genetic testing. But we should remember this recommendation comes from the European Society, may not be easy to implement in all babies in our part, but we need to know about that. So different techniques like the NGS and CGHRA, everything can be done for babies if needed. These are about some genes. And regarding the antenatal diagnosis, always remember that all antenatal mothers should be screened for hypothyroidism, and they need to be supplemented. And whenever there is a goiter which is identified during the ultrasound scans, because we all do antenatal ultrasound scans, when we are identifying a goiter, most of the time the baby may be having hypothyroidism, congenital hypothyroidism or fetal hypothyroidism, and which need to be treated. So if such a baby is if the baby is having congenital hypothyroidism and the mother is having hypothyroidism, we can treat the mother. We treat the mother and the baby improves. But if it is a euthyroid mother, most of the time we need to treat the fetus. So for that, we can use intra-amniotic injections of LT4, which is available abroad. And if the mother is having hypothyroidism, we need not treat the baby. We can treat the mother. So treatment of goiter is important because not only for helping the baby in fighting the hypothyroidism, but it will help the obstetrician also, because the goiter may have problem with the delivery, and also the baby can develop hydramnios and other complications. So the guideline actually recommends worldwide neonatal screening and appropriate diagnostics, and we should immediately start correctly dose the LT4 treatment as early as possible, and we need to have timely assessment, and consulting other health professionals is also important, and harmonization of diagnostic treatment, and planned transition of care from pediatrics to adult medicine. And we may have to look at genetic etiology of thyroid disease in needed cases. So this is just a flow chart on how to treat congenital hypothyroidism. You can start with a tablet of thyroxine at 10 to 15 microgram per kg, crush the tablet, mix with breast milk, and give early morning every day till 6 months of age, and then with water after 6 months. Do not give iron, calcium, or soya along with thyroxine. You have to repeat T4 or free T4 at 2 weeks, and T4 or free T4 and TSH at 4 weeks. T4 normalizes at 2 weeks and TSH at 4 weeks. There can be a transient elevation of TSH in pituitary resistance. And further biochemical follow-up is every 2 months till 6 months of age, every 3 months from 6 months to 3 years, and every 3 to 6 months till end of growth, and 4 weeks after changing the thyroxine dose. And regarding the monitoring, we need to keep the T4 in the upper half of normal range for that particular age, maintain the TSH in normal range, and reassessment at 3 years of age only according to the SPE guideline. And very, very rarely, if the dose is negligible, we may attempt it after 6 months of age. And growth, height and length and weight to be plotted at each follow-up visit in a growth chart. Bone age may be assessed if not growing well. Development is to be assessed and documented at each follow-up. Head circumference to be monitored. And thanks for your patient listening, and thanks for Dr. Manjusha, my erstwhile student and now assistant professor in pediatrics, for preparing these slides. Thank you.
Thank you, Dr. Ryaz. Now I invite Dr. Padmanabhan sir to start the discussion.
Yeah, thank you, Dr. Ryaz. This is the first time I know you have been talking all over Kerala regarding hypothyroidism. This is the first time I listened to you. It's a very interesting talk.
Thank you, sir.
Hypothyroidism is something which we used to enjoy treating when we were staff of the SATH hospital. We were the final. There was no pediatric endocrinologist or adult endocrinologist. The only adult endocrinologist was DC Matthew Roy at that time. Now, what I have seen is those days, first I will ask you a question. Those days we used to see children of 2 years and 3 years coming with hypothyroidism. Now it was a sad story. We would keep it for DCH exam. We would keep them for MD exam, start treatment. The father and mother will be very happy with us. But we knew that the prognosis is not that good. Do we still see these patients or not?
Unfortunately, yes, sir. But they are not from our part, but from bordering Tamil Nadu. There are still patients are coming. At least I think once in 3 months we get. In a year, 3 or 4 babies we get at the age of 6 months, sometimes 1 year, like that, with a untreated congenital hypothyroidism.
So now what has happened? I mean, I will tell you how ignorant I was. I had a girl who walked in from Tamil Nadu, and he had all the features of hypothyroidism. And I did it brought by the grandfather, did the thyroid function, and the TSH was sky high. The problem in those days where we used to start only at 6 microgram per kg per day. And Matthew Roy sir used to tell us, initially when you give, the tissues are hungry of thyroid. Therefore, you should give only a very low dose at the beginning for 1 week or 10 days and then increase. Now I realize that has all not gone. And those days, T4 TSH was very difficult to do. They used to do it only in RCC. And we used to practically diagnose whenever the X-ray knee showed no.
Yes.
And those were always detected. Now, the question here is, I have found when I went to the Gulf, the American guidelines came and they started a very aggressive type, even IQ losing by 5 or 10 points, I think they get sued. But the dose was kept on increasing, 6, 10, 15, and all that. And then, though we used to say 6 and all, the weight of a child is 3 kg. 10 microgram you want to give, we used to have only 100 microgram tablets at that time. So we can give quarter or half only. Now I understand 25, 37.5, 50, everything is available because my
12.5 starts with 12.5, sir. All multiples of 12.5 are there.
Therefore, you are able to adjust it in a much better way.
Yes.
But what I have found is that you are trying to give them a dose in which, if you follow too much the Western guidelines, you have to monitor more carefully.
Yes.
I don't know whether this test is available free in the Thaluk hospitals and health centers. I'm not sure. Because it costs some, if you do T4 and TSH, I think it comes nearly 800 rupees for the, am I right, in the private? Whether they will be able to do. Because when we started doing the American guidelines in the Gulf, suddenly we found many patients with hyperthyroidism. Unless you monitor them carefully, you may err. Therefore, you have to strike a balance when you are treating. And I now know that it is the endocrinologists who now treat the hypothyroidism mostly. The pediatricians may add here, and that's the only thing. Now, you said about the brand. Is it so important? I don't know, because Thyronorm, Thyroxine, sometimes you get Thyronorm, sometimes you get. Is it so important?
Sir, actually, I was reading from the guideline only. The guideline was telling about the difference between the generic and this thing, brand. So they concluded that brand is better than generic. But we can see that it was a weak recommendation. It was given 2 only.
Yeah.
So it's only a weak recommendation. So generic may be okay.
Do we have a generic thyroxine also available?
Actually, we have a different type of, we have some Thyrox tablet, which is available in the government supply. And I am finding is it equally good as any other brand, because we are giving it from the hospital and the results are good only. There are no issues.
Yeah, I think
the only thing is, sir, what I need to highlight is about dispensing of the thyroxine tablet. We need to dispense the tablet in the amber colored bottles only. We should not give it in paper cover or something like that, because these tablets are highly sensitive to heat and light. So it should be protected from heat and light. It should be kept in a cooler place, and direct sunlight should not come. So it is very important. And for the newborn, sometimes for making the dose approximate, we ask them to cut it, make it into 5 parts. It's not needed at all. You can give a dose of increments of 12.5 so that it is available, 12.5, 25. 37.5, like that it goes. Up to 175 it is available.
If the TSH is normal, even if the FT3 is above normal, that was something news to me. And if TSH more than 6, if you start treating, I don't know, because that I think we never used to do. But we are what has happened over the years is we have been very careful not only to treat moderate, but even mild hypothyroidism and keep them well controlled so that we are sure the IQ doesn't go down. But then you have to monitor them carefully. Thank you. Thank you very much, Doctor. Yes.
Thank you, sir. Thank you for the inputs.
I am Dr. Ashok Kumar from KIMS. Very good presentation, RIYAZ.
Thank you, sir.
RIYAZ has revolutionized the screening program in SAT. It was my dream when I was in SAT, but you have made it a success. What is your rate of identifying congenital hypothyroidism in the screening? One in how many deliveries?
Sir, in our hospital, it has come to around 1 in 1,100. So it is actually with this screening, this is happening world over, sir. The incidence is increasing because with a better test and more without any pilferage we are doing for everyone. Actually, the incidence is increasing, sir.
In KIMS, we started in 2002 when I joined KIMS. I think that was the earliest general screening because I was very keen on congenital, universal screening. And in 2002, when did you start? 2010 or 2000?
Sir, it was in 2012, sir.
2012, yes. Yes. Then this personal problem. My wife is taking thyroid tablet, but she is very particular about taking a bed coffee immediately after getting up from bed. So waiting for half an hour after taking the tablet is a big botheration for her. Any suggestion?
Sir, I think we need to look at only the value, sir. If you are getting the T4 value in the normal range, I think it is okay. Because for children also, it is very difficult because when we are telling that you give the thyroxine tablet in the morning after the child is getting up and don't give anything for half an hour, I don't know how many of the parents and children are following it up. Because it's a lifelong activity. So I don't know, sir.
In UK, my daughter-in-law is there. They're very particular about TSH level in the pregnancy. I did not know that 2.5 was the expected level of thyroid TSH in pregnancy. I was thinking 5, but they are very particular about TSH level in the pregnancy. Here, are we screening for TSH level in pregnancy?
Yes, sir. Everywhere now gynecologists are doing, because the American Thyroid Association has brought out this guideline, and they were telling that there is an increased incidence of adverse events both in the baby as well as the mother. The preterm delivery, even APH, many things they are telling. So in most of the countries, I think in Kerala also, I think in SAT, in KIMS, everywhere the gynecologists are doing this. They are screening for
cutoff of TSH is 2.5.
2.5. Actually, it is 2.5 in the first trimester and 3 in the next 2 trimesters for normal pregnancy, and for those mothers who are having congenital hypothyroidism, it is 2.5 in all pregnancies. But it is very difficult, sir, because I also have at least 1 or 2 children who were actually your patient and Lalita Madam's patient. After that, I was following them up, and now they have children and all. But I was not able to keep it up to 3 and all, because with the very high dose, even with the 200, 250 microgram of thyroxine, it hovers around sometime like 5 or something, because
My God.
in congenital hypothyroidism, it is very difficult.
No, even for normal women without apparent hypothyroidism, during pregnancy screening, they detected hypothyroidism. So usually 2.5 is the cutoff. So, till then, they were not hypothyroid earlier.
I have asked this question to a few of the adult endocrinologists also, sir. But what they're telling is this this guideline is based on some studies which tell that if the TSH value is more than 3 or more than 2.5, there is increased incidence of adverse pregnancy outcomes. But it's not our area anyway. Like,
Can I interfere? Because sometimes I had a high TSH for a long time and I used to ignore it until I contacted once John Pindus, who's an endocrinologist in now St. Stephen's, Delhi, and he was 1 year senior to me. He said, do your autoimmune antibodies, which was not done regularly at the time. It came sky high. Therefore, this autoimmune thyroiditis is very, very common. And both my daughters are autoimmune thyroiditis with high TSH. That's why I consulted RIYAZ also recently. Therefore, this may go undetected and they may just have a high TSH, and when they become pregnant, I think they can create problems unless you treat the hypothyroids. Therefore, if Ashokuma sir is telling that is detected during pregnancy, it is better to do the antibodies also. If the antibodies are positive, then you require lifelong treatment. If the TSH is high. Am I right? Yes.
yes, sir. Yes, sir. Like even for children, because this subclinical hypothyroidism, that is the TSH between 5 to 10 and T4 normal, in children, regarding treatment, there are two schools of thought. One is that you give a small dose or you follow. So what the guideline is, if the antibodies are positive, or if the child is having a goiter, better to give a small dose and treat. Because sir told that if the antibodies are positive, there is a very high chance this child will develop overt hypothyroidism during the due course. So it is better to start treatment with a small dose.
I think it's time to stop.
So any more questions from the participants? I think no more questions. So
I will ask a question to you, Pradeep Kadamani. In our
yes, sir.
times, we general pediatricians used to treat hypothyroidism with confidence. Will you treat a patient if it comes to you, or you will just send it away to RIYAZ? Because nowadays, that's what I find.
Can I because I ask all my students to treat congenital hypothyroidism, because actually it is not needed, sir, because the follow-up is very important. And actually, it is very difficult for the patient to come from far off places or follow up to a center. It is the pediatrician can follow up. There is no problem at all. There is no problem at all.
Actually, I always refer my patients whenever there is a doubt to Dr. RIYAZ. And
when there is a question, we can.
So when I'm in doubt, yes, definitely yes.
I think the best model is to start the treatment yourself and say that there is no pediatric endocrinologist. If you want, you can take a second opinion. Therefore, that when he reinforces that what you are treating is right and we are going by guideline, then it becomes a good this one. If you give every epilepsy to neurologist, every nephrotic syndrome to the nephritis and nephrotic syndrome to, that's what is happening now. The patients actually suffer. That's what I have seen. Close follow-up is required for these. And now there is a tendency to not to take the responsibility. That is there. Anyway.
Okay, since there are no more questions, we'll wind up the session. So thank you very much, Dr. G.S. Vijayakrishnan, Dr. Riyaz, Dr. Padmanabhan sir, Dr. Ashok Kumar sir, and Dr. Altaf, Dr. Anand Martanda Pillai, all the senior leaders who participated, all my colleagues and friends. Thank you once again. And please join in all the upcoming sessions of AMS Trivandrum chapter and make all our sessions successful.
Can we get
Thank
this
you.
presentation? Will it be uploaded?
Yes, sir. Yes, sir. Sure.
I can pass it on to Pradeep sir. So that.
Now we're having a YouTube channel.
Okay,
So we'll be uploading it in YouTube
Okay.
channels.
Okay.
Thank you. Thank you.
Thank you,
Thank
sir.
you,
very much.
Okay. Good night.
Good night.
Good night. Good night.